Be talking about the boundaries of LAA closure. I have no disclosures. So, you know, when we talk about pushing the boundaries today, 2019, what are we really talking about? Well, of course, there is ongoing study of new devices. You're going to hear more about that in some of the other presentations. I won't go into that too much. This talk will focus more on the boundaries that we're currently looking at with commercially approved devices, which is the WATCHMAN. We are also conquering more challenging LAA anatomy. We've all heard about the tight anterior chicken wing cases, but there's other issues there, such as large left atrial appendage ostium size. So there's some novel things being done for that, which need further study. Pre-implantation or intraoperative imaging is another area in which we've made some strides, and there's more work to be done. Also, the minimalist, so-called minimalist approach to LAA closure. And then antithrombotic therapy duration, what should be your choice after implant? What's the minimum duration? And there's some studies going on with that, of course. And then LAA closure after partial surgical ligation is becoming an increasingly reported and published issue, and there's in fact efforts going on now to collect cases to report the outcomes on that. Patient selection is another area in which the boundaries are being pushed, and of course indications for closure and trying to expand indications with commercially approved therapies. So these are the different percutaneous left atrial appendage closure devices. Of course, I'll be focusing on the WATCHMAN device today, which is the only FDA-approved commercially available device, and you'll hear some more about some of these other devices, I'm sure, in other presentations. So as far as challenging LAA anatomy is concerned, there has been a report on double device closure of the left atrial appendage for large LAAs. There was a case series of 8 patients that had this technique used out of 319 consecutive cases. The WATCHMAN was implanted first in all 8 of those cases. And the second device that was used to fully close the appendage was either an Amplatzer vascular plug 2, AVP2 plug, or a second WATCHMAN device in 1 out of the 7 patients. And the deployments of these 2 devices was simultaneous in 5 out of the 8 cases. It's unclear what the impact of this type of technique is on endothelialization. You have 2 devices, kind of nitinol on nitinol, or metal on metal, so to speak. We don't know what the long-term endothelialization progress of that is. There also is an unclear understanding of the residual leak that might occur with this sort of thing. In the cases that were reported, the ostium or the appendage was felt to be closed, but on further subsequent imaging, there were some leaks. And then, of course, as we just heard about device-related thrombus, we need to better understand what a technique like this would do to that. Closure of the LAA after prior surgical ligation is also something that's been published on, and there's efforts, as I mentioned, to collect case series on this. But they're looking at a stability of the prior surgical suture determining your device choice. So if the suture is loose, or you think you can get something a little bit larger in there versus if the suture is tight, or what portion of the appendage is open to you, that might determine device choice. And you have to size the leak channel appropriately. That can be done with a number of imaging modalities such as CT or 3D TE or TE. Off-label options to close this would include an AVP2 or an AVP plug, a cardioform, a Gore cardioform, or a WATCHMAN device, potentially depending on the size of the residual channel. And researchers, as I mentioned, are completing a retrospective analysis and trying to gather these cases to report the worldwide experience with this. But this is an increasing issue that we're all aware of, that we'll continue to see, I imagine, as some of these patients come back. So we need some novel techniques to handle this, and so this is what's currently being done. Using PFOs for LAA closure. So I'm not, just by a show of hands, has anyone done this during LAA closure, gone through an existing PFO? Okay, so in the last couple of days, we've heard so much focus on the importance of choosing the correct transeptal puncture location, obviously inferior, posterior, kind of having that trajectory up to the left atrial appendage. But in my personal experience, which of course is a small n compared to the thousands and hundreds of thousands of cases done worldwide, but in my personal experience, I've actually had a lot of success using PFOs. In fact, when a PFO is present in my patients, I use it about 80% of the time, and the use of a PFO to close the left atrial appendage in my cases is about 16% of my cases where I'll use a PFO. So, we know that the incidence of PFO is a general population, and if you go through, you actually can close the left atrial appendage successfully, as I've experienced, without having to change your sheath or use multiple devices or do multiple recaptures, and you don't have to make another transseptal puncture. So I want to challenge, sort of in this slide, I'm kind of challenging the thinking that you don't always have to be inferior posterior. And anyone who's closed a PFO might have noticed that when you cross a PFO with a J-wire, it often goes to the left atrial appendage. So obviously everyone's anatomy is different, but my experience here is that this is a potential, backdoor approach, if you will, to getting in and closing the appendage without necessarily making another puncture. And, I've had good outcomes with this. So I'm actually, if anyone's interested, collecting cases of this to try to write this up. And so if anyone's interested, please talk with me. But there are some procedural considerations in doing this. You have to often use a single curved sheath, as I've found, and oftentimes I'm aiming for a neutral lobe or a more posterior lobe to close the appendage, so slightly different technique if you're going to be using a PFO. But I can think of numerous cases where I struggled to close the left atrial appendage because my transseptal puncture was not quite ideal. But I can think of tons of cases where I went through a PFO and was able to close the appendage very easily. So I would challenge and submit to you that you don't always have to be in the quote-unquote ideal or right spot on the septum to close an appendage successfully, and this may be something to look at in terms of pushing the boundaries and minimizing transseptal puncture, which potentially could minimize complications of morbidity. So as far as expanding indications for patients and selection of LAA closure, we have several IDE trials going on. The PINNACLE FLX trial, the WATCHMAN FLX device, currently investigational, not commercially available. But in this trial, single-arm, non-randomized study, DOAC-only options post-implant, 400 patients, 29 sites. As you probably know, the enrollment is complete. The specs of this device are interesting. It's about 10 to 20% shorter in length compared to the traditional WATCHMAN device that we use currently. It comes in 5 different sizes, anywhere from 20 to 35 millimeters, covering an ostium measurement of anywhere from 15 to 32 millimeters, so slightly larger range from the current standard WATCHMAN device, IFU. Increase in the number of struts, 18 struts versus 10 struts, more anchors, 12 anchors with a J shape to them. An atraumatic end, as you probably know, you can actually deploy the device and push or pull it in the appendage without being worried about the potential chance to perforate the appendage. And it is fully covered to minimize leaks. So we'll be interested to see the outcomes of this trial and how this is used in commercial practice. My guess is that this will probably be adjunctive to the existing WATCHMAN, but not necessarily replace the current device. The ASAP-2 trial, we are probably all familiar with this. This is basically looking at randomizing patients to WATCHMAN versus no WATCHMAN. And if they're randomized to WATCHMAN, they get 3 months of dual antiplatelet therapy, followed by single antiplatelet therapy thereafter, versus if they're randomized to no WATCHMAN, you put them on, single antiplatelet therapy, which is usually aspirin. And so here is an example of a trial that's looking at the safety and effectiveness of closing the left atrial appendage with a WATCHMAN and cutting down on the duration of DAPT. And as we all know, that's certainly something that we are doing and wanting to do for some of our patients with high bleeding risk. Many of us are using data from the Evolution registry, which has been well studied and well kind of dissected, to put patients on 6 months of DAPT after left atrial appendage closure. This trial would potentially allow us to cut back on that duration to 3 months. The challenging aspects of this trial that I've personally found is enrollment. And as you look at the national pace of enrollment for this trial, it has been a lot slower than intended. But I think there's a lot of reasons for that. But certainly, I think this is a very important trial. And it'll be exciting to see what the outcomes of this trial are in pushing the limits for DAPT duration post-implant. PROG 17 is looking at LAA closure versus the NOACs or DOACs. This is an OUS study being conducted in the Czech Republic, 400 patients. It's a randomized parallel assignment study with NOAC versus LAA closure, either with Amulet or WATCHMAN. And the primary outcome is the combined stroke or systemic cardiovascular event or significant bleeding or death or procedure-related complications. So it'll be interesting to see, how the WATCHMAN fares in comparison to NOACs, because in clinical practice, as we all know, some physicians will take patients who have labile INRs or bleeding on warfarin and switch them to Eliquis before considering left atrial appendage closure. Studies like PROG 17 and others may challenge that practice. The option trial, this is interesting. This is looking at basically closing the left atrial appendage after an AFib ablation to try to minimize the need for oral anticoagulation for post-ablation patients. It has a device group and the standard control group, which is to put the patients on an oral anticoagulant after their AFib ablation. And it's powered both for non-inferiority and superiority. WATCH-TAVR trial, you may have heard about this. This is looking at randomizing patients to TAVR plus medical therapy. That is patients who have severe AS and concomitant AFib, as about a third of severe AS patients do, or randomizing patients to TAVR plus WATCHMAN. This is going to be an interesting study as well. The minimalist approach to LAA closure is something we've probably heard a lot about recently, looking at pre-procedural CT scan for LAA sizing and planning instead of traditional TE, minimizing the need to do this invasive TE prior to the procedure and then doing it again on the day of the procedure and again 45 days later. Moderate conscious sedation, which would either involve doing the procedure with ICE guidance, either putting the ICE catheter in the left atrium itself during the procedure, or looking at using a pediatric TE probe, which has also been reported. And I think this has huge impact on potential referral to table time for those of us that are running programs and trying to grow our programs. And certainly might potentially optimize or further refine procedural economics in certain health systems. We are lucky to have Dr. Wang in the audience today, and I'm sure she'll be talking more about this. But the whole idea of pre-LAA closure using the CT scan imaging technology, which had been reported a couple years back in 53 patients in a single center experience who had LAA closure with a WATCHMAN device. And this is a great paper by Didi that really nicely outlines the imaging protocols, the sizing protocols, and a planning algorithm for where you might want to land your device and really better elucidating the depth of the appendage. And CT does an incredible job at this, as I'm sure you'll hear from her. So looking at 3D CT versus TEE, there's several interesting findings, but kind of the summary of it is this, that if you look at a 2D TE measurement, 33 out of 53 patients would have required a larger device if you compared 2D TE versus the better imaging on CT. 3D TE, 28 out of 53 patients in this study would have required larger devices. So 3D TE refines the sizing, certainly compared to 2D. And in terms of 3D TE LAA length measurements, it would have excluded 10 out of 53 of these patients for a WATCHMAN had they not had a CT to see that, in fact, they did have adequate length. So some really exciting things going on with CT. Of course, there's some limitations to this. You have to have availability of the imaging technology at your center and adept readers. But the industry companies can also help with looking and processing your CT images to try to help guide you. But this is, I think, an expanding area of pre-procedural LAA therapy assessment. So in conclusions, to wrap things up, we are pushing the boundaries of LAA closure. I think that it's not just only being done in terms of tackling more challenging left atrial appendages, but also using some novel techniques like double device closure and some other things that I think require further study. We're increasing our patient selection and expanding the scope of indications for patients by way of current ongoing studies, and it'd be interesting to see what the results of that are. We're looking at trying to expand the approved scenarios for LAA closure with some of the ongoing studies. Post-implant antithrombotic therapy options, trying to minimize the time on oral anticoagulants or antithrombotic therapies, or potentially delaying treatment by switching from warfarin to a NOAC, and so we'll see what the results of those studies are. And then expanding the scope of pre- and intra-procedural imaging, whether it be CT imaging prior to the procedure and then going on to do a minimalist LAA closure, and how much that's going to catch on is going to be interesting. But certainly, I think there's more to be done in that space and potentially making this procedure not only economically even more feasible than it already is, but also potentially making it less invasive for our patients, which would help with peri-procedural complications for sure. And then, I think overall I would just say that this is a rapidly growing space. There are new devices coming down the pipeline. We're going to hear more about that, I'm sure. But in terms of the commercially available therapies, I think these are some of the ways in which we're currently trying to push the envelope with LAA closure. Thank you.